Excellent. All right. Well, we do have some great questions. I think the first question is for Christian, and it has to do with the biomarker test for bleeding risk. Is that something that is available with a fast turnaround so that if you use it within the hospital setting or the ED setting with initiation or consideration of initiation of anticoagulation, will you have those results back?
Yeah, it's a great question. As Caitlin mentioned, the bleeding score that is likely going to be adopted, at least for atrial fibrillation, is the ABC bleeding risk score, which has just very specific clinical factors. And then the biomarkers are three of them: hemoglobin, which is widely available, obviously, and rapid turnaround; troponin, and the GDF-15. And the GDF-15 is still for research purposes. It is undergoing FDA approval. And so I think people feel that currently you couldn't use that full risk score for clinical use because their GDF-15 would not be available universally, or rapid turnaround. It's mainly for research purposes, but it likely will be in the near future. But you can use, obviously, if you can look up the paper for the ABC risk score, Lars Wallington had publicized it. You could measure modified, which would be without the GDF-15, but it's likely going to be adopted, I would suspect, in the US probably within the next 1 to 2 years.
And do you envision that it will be something that will have a rapid turnaround, or is that something?
I do think, and it's being developed to have a very rapid turnaround. And as Caitlin mentioned, the nice thing about it is it seems to, a lot of the bleeding risk scores do identify bleeding risk, but also stroke risk, and so it's very hard to kind of tease it apart. But the ABC bleeding risk score, which uses GDF-15 in particular, which is the strongest marker of bleeding, seems to only predict bleeding risk independent of stroke risk. So I think it'll be helpful to really identify patients who might be at a higher risk of bleeding. And to be honest, we've actually done some work in it in clinical trials. And what it actually does the most is if you have people use the Has-Blood score. Has-Blood score tends to overestimate bleeding risk significantly in AF patients. And so the ABC bleeding risk score actually tends to more appropriately de-risk patients. So I think it'll give physicians and patients a lot more confidence that just because you're older and have 1 or 2 comorbidities, you're not nearly at high a bleeding risk as most of us think just from the bedside.
Excellent. Another great question, perhaps for Nathan or Jean or Caitlin, is do we have guidelines within the hospital for approval of Kcentra, that's prothrombin complex concentrate, outside of the realms of intracranial hemorrhage? What about for emergency surgery? I know this is a hot topic.
Yeah, no, I'll take that because I'm the medical director of our hemostatic antithrombotic stewardship program, and Caitlin's our operations manager, and Nathan's one of our hematologists. We have guidelines for a lot of different things, and not everybody in the hospital is aware of them. At our particular hospital, they're on the computer and available to everybody. It's very important for your hospitals to have these and understand how to use them. I think it's more so for idarucizumab and indexinate that we worry about, surgeons wanting to use them because they forgot to tell their patient to stop the dabigatran the night before elective surgery. For 4-factor PCC and Kcentra, our biggest problem is not so much people trying to use it for reversal, and we have some reversal strategies that I'm happy to discuss or share, and I can give you our email address. But we find our surgeons using it in the OR for totally off-label indications to achieve hemostasis after cardiothoracic surgery. So that's one of our concerning. So it's appropriately used in our emergency room. Our staff there know how to use it. It's appropriately used in our ICUs, and we have guidelines that help people determine when, and not only when, but what dose.
Excellent. And this next question, I think, is for Dr. Campia. During surgeries that are particularly long, there's the potential that you might have re-anticoagulation develop. How do you manage that? Do you need to redose hemostatic agents? Do you need to check INRs in patients who are getting surgery?
So in this case, it depends on the surgery, depends on the duration, depends on the individual patients. I don't personally think we would have an indication to recheck INR during the surgeries, but again, it depends on the individual surgery.
Okay, excellent. This is a tough question. Maybe for Christian, you end up talking a lot to patients about particularly stroke prevention and atrial fibrillation. How do you speak to, this is a good question, patients who are Jehovah's Witnesses, where the risk of bleeding and your ability to resuscitate the patient can be limited?
Yeah, no, it's a challenging question. We certainly obviously always want to respect patients' wishes and beliefs. I will say, you know, as I mentioned, for the majority of patients, even elderly patients, so you're talking about patients in their 70s who often have comorbidities, that, you know, even if you look at the overall rates of major bleeding is only about 3% per year, but the number of those patients who actually require blood transfusions is quite small. And so even for patients who are Jehovah's Witnesses or patients who feel strongly against any blood products, the risk of actually having a major bleed requiring transfusion is really quite small. And I think Caitlin's point about there are a lot of things that you could further lower that risk. You know, that includes, all those bleeding rates include patients on antiplatelet therapy, patients on NSAIDs, you know, obviously appropriate dosing. So if you go through that checklist and modify a lot of the things, I think with those patients I say, let's do everything we can to make sure you don't have a bleed. Do not take NSAIDs if you don't need them. You have no need to be on aspirin for primary prevention. Make sure you're on the appropriate dose. I use the safest NOACs with respect to major bleeding. They're all the same for life-threatening bleeding, but some have a little bit better bleeding profiles for major bleeding. So there's a lot you can do to further lower that risk. So their risk of getting a blood product is probably well under 1% per year, maybe 0.5% per year or less. So that's actually quite low when you consider that their risk of having a stroke over 10 years off an anticoagulant, you know, may approach, you know, 20+%.
Excellent. Here's a question, I think, for Dr. Connors. This is a loaded question. I'm going to read it as is. I'm confused. If the prothrombin complex drug fixes anticoagulation, why do we need fancy antidotes?
Yeah, so that's a great question. The data are not there for four-factor PCC. And so if you all remember, everybody in this room looks old enough to remember when dabigatran hit the market, right? And so we went from warfarin to dabigatran, and all of a sudden there was quite a stir in the lay press about all the bleeding associated with dabigatran and how terrible this was, and why did this product make it to market? When in reality, I'll never forget the first head bleed that came to our emergency room on dabigatran, and there was a lot of chatter about head bleed, dabigatran, terrible drug. But what people didn't realize that in that same month we had 3 ICH on warfarin. So in response to the dabigatran sort of lay press hoopla about bleeding, the company rightfully made a very specific antidote. And there are no data for PCC really reversing dabigatran. So if you have a patient on dabigatran, you really need to use idarosizumab. And at the time the idarosizumab trial was developed, again, we're talking, remember, dabigatran was the first to hit the market. It was determined that it would be unethical to randomize somebody off the street coming in with dabigatran-related bleeding to a randomized controlled trial, because what were you going to randomize to? And, there's some waffly data about FIBA reversing the dabigatran. FIBA is factor VIII inhibitor bypassing activity. It's a 4-factor PCC, but it has activated 7. So move from that experience to now we've got andexanet, which binds specifically to 10A inhibitors and neutralizes and reverses the anticoagulant effect. And that's very different than just dumping in extra factor. You can give somebody, if you take your 80-kilogram man and you give him 50 units per kilo of 4-factor PCC, you can essentially give that patient 16 bags worth of factor 10 in 100 cc's of fluid. Okay, so we're talking 16 bags worth of FFP in a short volume. But whether that stoichiometry is enough to overcome the drug concentration isn't clear, and it's felt that it's not that. So we don't, PCC was a response to the lack of specific agents, but it's not clear that PCC really is effective in reversing. And if you remember the last comment in my presentation, the blood advance paper, it's not clear that PCC is any better than just stopping the drug.
Excellent. So we've got a lot more questions that have come in, and we're going to switch to speed round now, where I'm going to ask for one-sentence answers
that was
for all
too
of
long.
these. No, it had nothing to do with that. It's the fact that we got 7 questions in the last, 5 seconds. All right, so here we go. This is for Jean. Relatively speaking, can you comment on how expensive the DOACs are relative to warfarin and the relative price of the reversal agents?
Yeah, so I'm the wrong person potentially to speak on cost, but I intimately know the costs. And the reason is because I work in the cancer patient population. So for years, low molecular weight heparin was the only anticoagulant of choice, and some patients have to pay $4,000 out of pocket for low molecular weight heparin. So DOACs, warfarin, what we're not looking at when we compare cost, if someone has to pay maximum $300 a month out of pocket for a DOAC, insurance companies, I still don't understand their coverage. They're all over the map depending which insurance company, whether one's a preferred agent or not. The cost is definitely different, but what's not figured into the cost, warfarin may be $6 a month, but we have to factor in the costs of our pharmacists, the cost of blood tests, the cost of managing the anticoagulation, which no one's really done. So I think for the patient, DOACs are, many patients would rather spend $25, $50 a month than the $5 to $10 for warfarin and be free of testing. Some won't. Yep. Some like to know that their INR is in the range. With regard to reversal agents, again, in the days of using recombinant 7A, and particularly for hemophilia patients, which we see in our practice who have inhibitors, and we're giving them, 120 mics per kilo of Novo 7 at over $15,000 a dose every 2 hours for 24 hours. The costs of reversal agents are clearly a factor. So 4-factor PCC and idarosizumab are roughly around the same. Idarosizumab maybe $3,500 to $5,000 a dose. PCC somewhere in that range depending on the weight. Clearly there's been a lot of press about the Indexinet cost. Essentially $25,000 for the standard dose and about $48,000 for the high. However, if I were a patient with life-threatening bleed, I would want you to give me a reversal agent that is specific and targeted.
Nice. All right, so now we're going to super speed round, and we're talking one-word answers if you can manage it. All right. No, I'm serious. So, Caitlin, with the Anticoagulation Management Service, the DOAC Management Service, have you done anything to quantify the potential benefits of this? Have you seen reduced bleeds?
So, in one word, we're collecting data on the number of peri-procedural plans we design, the number of dose adjustments we have to make, and those are they're more workload metrics still. We don't have a great assessment tool to say what our quality of care is.
Excellent. Let's see. This is a question perhaps for Nathan. Should you use both PCC and tranexamic acid for bad bleeding?
It's a good question.
You just used your word.
Yes. I think if you're faced with a critical life-threatening bleed and you're in an area that has high fibrinolytic activity, you're talking about oral mucosa, you're talking about somebody with a prostate bleed, somebody with GU tract bleeding, you have to be careful with GU tract bleeding. But in other areas, I think that there's very little downside, especially if somebody's got the potential of dying in front of you.
Good, very good. Let's see. Umberto, any thoughts on using DOACs for bridging warfarin?
Yes, the answer is no.
Good. Let's see. How much time does it take to prepare the Andexa, and does that weigh into your decision making in using that?
Yeah, so we published our case series of the first 15 patients we treated, understanding that we had a lot of experience from being a major trial site, and it was about 20 to 40 minutes from the time the order was written to the time it was delivered. We have 24/7 support in our cell products room, though, and the technicians are quite adept at mixing, but our times are 20 to 40 minutes.
Excellent. What would you say, maybe Christian, what would you suggest for an elderly patient with atrial fibrillation who can't take edoxaban because it's non-formulary but really needs to take a once daily drug?
Yeah, I say do not mix and match. If you have a once daily drug, your only options are edoxaban or rivaroxaban because you have to have different milligrams per dosing, so you would have to opt to a twice daily agent. There would be no other option unless you're going to use rivaroxaban.
Excellent. And let's see, maybe for Umberto, when you tell patients to stop aspirin, even in the setting of the perioperative or procedure or surgery, are you worried about rebound arterial events?
No, not really. And aspirin usually inhibits platelets. You have a full inhibition and it is irreversible. So you have a reconstitution of platelets. You don't have necessarily a hypercoagulant state. So I wouldn't expect.
Excellent. And with that, it's 8:30 exactly. Thank you very much. Thank you to the great faculty, and have a great night and hope to see you at the next event.